Okay, healthcare is 18.5% of the US economy, but healthcare is not monolithic. It's 5,700 hospitals, it's 800,000 doctors, it's 15,000 nursing homes, it's 10,000 home health agencies, labs, imaging centers, medical devices, pharmaceuticals. It's not monolithic. However, part of the assertion today will be, I believe, healthcare will be the pinnacle platform industry. It's going to take a decade, and I'll explain that. We have a distinguished panel today, and I'm going to introduce them. A little overview of how the session's going to work. I'm going to offer a couple of contextual slides, provide some perspective of the big picture of healthcare. Each of the panelists will have 3 minutes for opening remarks. Then I've got some questions. I'll probably go through a couple of them to prime the discussion, and then we'll open it up. You can ask whatever questions you would like. So let me introduce, in the order of shown on the slide, Mark Dudman, Senior Vice President from Navinet. If you can raise your hand, Mark, so people know who you are. Michael Jackson, who I'm going to refer to as MJ, because we have two Michaels from Intel. He's the snappily dressed one. And I've been in half a dozen Intel facilities, and I've yet to spot a necktie. So I thank you for I thank you for the fancy, the respect for the conference. Michael Salerno, the Chief Product Officer from Cohilo, and Julie Yu, co-founder, Chief Product Officer from Kairos. Did I get that right? Okay, I did. And I'm Vince Kuraiti. I work as a healthcare consultant. I'm writing a book around what I'm calling platforming healthcare. And let me try to provide you with a little bit of context with healthcare. So I've been around healthcare for 30 years. And until about a year ago, I've been speaking in the future tense, saying healthcare is on the cusp of change. And I've changed the tone. Today, the operative word is present tense. Healthcare is changing. And I'm going to describe for you what are some of the key drivers. If you had to put it into a phrase, the catchphrase within the industry has become from volume to value. Volume referring to the incentives that care providers have to do stuff, to do tests, to do procedures, to do hospital days, to do pills, going to value. And you've already heard references today to outcomes measurement. That is where the industry is heading right now. And the federal government has said it would like to have 50% of Medicare payments tied to reimbursement for value. One is really, it's payment reform. It's about the economics. And going from fee-for-service, where we have in the past traditionally paid piecemeal, to a value-based accountable care reimbursement model where at least some, and in most cases a substantial or perhaps entire amount of revenue is based upon performance and outcomes. The second driver is really the theme of this entire conference. It's the digital age. And I'll make a metaphor and say, I don't think this has really hit healthcare yet. Once the incentives begin to take place, and they are, then we will see the massive transformation. And third is the consumer revolution. Now, the problem with healthcare is it's very difficult to get information. And think of the challenge of healthcare as an information problem. Information data doesn't move very well. You want to get a price on a procedure. Very difficult to do. You want to find quality recommendations on physicians or doctors, almost impossible, but that's all changing. And healthcare, the decision-making, the role of Dr. Welby as the fountain of all knowledge no longer is the paradigm. The healthcare platform void, let me talk to you a little bit about that. In one sense, platforms have not yet in a big way entered healthcare. And the next slide is going to contradict that, but let me tell you what I mean. Contrast the healthcare world with the smartphone world, where you have two dominant platforms, iOS and Android, with 1 million plus apps each, huge ecosystems. But the world of healthcare is really just the opposite, where what you have is, the numbers have shown somewhere around 40 to 100,000 apps, but they're disconnected. There's no widely adopted dominant platforms yet in the healthcare world, and that's part of the opportunity. Healthcare will look a lot different. A lot of the platforms are going to be regional, not necessarily national or international. So again, using the present tense, healthcare is being platformed from the top down by some of the largest tech companies who have, many of whom who have entered the industry within the last year and a half. Health Kit and Research Kit from Apple, the SAMI platform from Samsung, et cetera. Big names. Traditionally, these have not been companies in healthcare. And then probably ones that if you're not in healthcare you won't recognize, but I just want to get on your radar screen. Essentially what's happening is a discussion of a private-public platform infrastructure as being described by the term that's being used as a public API being developed through HL7 Fire, the SMART project, the Argonaut project. You can Google those terms and learn a little bit more about them. But that is one way from the top down where healthcare is being platformed. From the bottom up, hundreds of early stage companies. We have several of those here today. They'll talk about their perspectives. Here I think it's really relevant to echo the words of Peter Thiel, one of the early investors of Facebook, who talks about when you build network effects, think as small as you can and start with a network where you can dominate it. That's the kind of platforms we're going to be seeing in healthcare. Why is healthcare the pinnacle platform industry? Well, first, the value propositions. They're strong. They're life and death. I mean, who else can make those sorts of claims? And many of the value propositions depend upon interoperable platform infrastructure. If you are in an automobile accident, you go to the hospital, and your records are on one platform and the hospital's on a different platform, it doesn't work. If you are a patient with a chronic condition, you have diabetes, you have asthma, you have COPD, and you have multiple care providers. You've got doctors and hospitals and labs and pharmacies. If they're all on different networks, the value proposition doesn't work. It will require great harmony and interoperability among different platforms to be able to achieve many of the value propositions. The need for interaction goes far beyond today's existing platforms. A lot of the problem of healthcare just simply is it's a bunch of silos and they don't talk to one another. And today's platforms, you think of Amazon, it's a simple transaction. And Amazon does gather a lot of data, but the transaction and the value is independent. So again, if you're a chronic disease patient, the interaction you're going to have with the healthcare delivery system and the platform is going to be longitudinal. You're going to have your diabetes for the rest of your life. So it really boils down to number 3, where platforms will be enabling a collaborative workflow, which will be far more valuable and far more complex than the kinds of platforms that we've seen in other industries. And finally, the data explosion. Just simply think of all the omics that are out there. It's amazing how big data will be transforming healthcare. But to be realistic, there are many barriers along the way. Cultural, regulatory. I'll point to the last bullet point just briefly and say ONC, that's the Office of the National Coordinator for Health IT, has developed what they refer to as a 10-year plan for interoperability. So, this is going to evolve incrementally. It's going to come in stages. It's not been an easy process. So, with that, I'm going to allow the panelists to briefly introduce themselves. And Michael, why don't you go first, and we'll just go 1, 2, 3, 4 down the line, starting from your left. You've got 3 minutes, and I've got my stopwatch running.
Which Michael? Is Michael?
Okay, Michael, MJ at the end.
Right. Okay, got it. Great. Is the mic working? Excellent. Thank you. I'm Michael Salerno. I'm the Chief Product Officer of Cohilo. We are a technology provider that's offering a platform for the medical device industry. Just to kind of give you an idea of what's happening, as Vince has been saying in the healthcare industry, the reimbursement policies have been changing. A lot of downward pressure on hospital systems. Therefore, their budgets, or capital budgets, have been compressed, and that in turn has to be balanced with improving care. So what we're trying to do is we're trying to help them strike that balance by offering a platform that essentially allows them to share expensive medical equipment. So in other words, what we're doing is we're bringing this sharing economy model into healthcare in terms of medical equipment. This model is intended to improve access for physicians to get to the devices that they need. A very expensive medical equipment. For example, there's a doctor I talked to who wanted to have this particular blue light laser. It cost $160,000. He was turned down. Why? He didn't have enough patient volume. But in a healthcare network like those of our customers, of the Tenets of the world, the Kaisers of the world, they have many hospital systems in that system. If you aggregate that demand, and you can now have that information to say, yes, you can purchase this device, but purchase one, which then can be shared, right? So it gives the physicians a better access to that type of device, which in turn leads to better outcomes. And on the flip side of that, for the hospital system, they can fulfill these demands for equipment without having to expend a tremendous amount of capital. So that's the type of platform that we're delivering. And hopefully my 3 minutes are up.
Nope, you got 30 seconds.
30 seconds, okay.
All right, well, you can hang on to that. Julie, again, Chief Product Officer, co-founder of Kairos.
Yes, hi everyone, good morning. Julie Yu, Chief Product Officer, co-founder of Kairos. Kairos is a smart search technology that helps get patients to the right doctor. A very seemingly trivial statement that in operational worlds are very hard to accomplish. Doesn't happen anywhere as nearly as we'd like to think that patients are actually getting to the right place the first time. We also help with the scheduling and referral management process. So a lot of the platform play that we're taking on is how do you actually bring real-time intelligence to the scheduling and referral workflows that, if anyone has experienced this, traditionally have been extremely data poor and extremely asynchronous. So that is sort of what the technology does. The business problem that we solve, and our customers are very much the same as Michael's customers, the large hospital systems of the world. Our value proposition to them is that we help them solve what we call the patient access paradox. It's this notion that we as patients are told to wait weeks, if not months, to see a doctor. In fact, Boston is the #1 most notorious city in the country for this in terms of appointment wait times and access. And one would assume that that's because every doctor is booked out solid, that every schedule is 100% full, and that there really is no room in the system. What we found early on, about 4 years ago when we founded the company, is that as you look at the data, as you actually look at the capacity, the schedules, relative to the expected full-time, the FTE status of providers that are on a staff, these hospital systems are shockingly operating at as low as 50 to 70% capacity, meaning that for every 10 slots that are available on their calendar, 3 to 5 are going unused every single day. And obviously that is decaying inventory that once it's gone, it's gone. So huge opportunity to really kind of close that gap between the demand that we represent as consumers of healthcare and the supply that sits on the provider side of the network within these hospital systems. So the way that we actually think about our platform is essentially doing for healthcare what the Sabre system, if folks are familiar with Sabre from the travel industry, what Sabre has done for the travel industry in terms of, number one, unifying the way that we can view inventory across multiple systems. So our average customer has between 5 and 20 different scheduling systems represented across their multi-thousand provider system. And therefore, there is no single way, prior to the deployment of our solution, for them to see all of the available inventory inventory, appointment inventory across their network in a single place. So first and foremost, we're doing that. Secondly, we're taking a rules engine-based approach to, again, ensuring that patients are getting to the right doctor. The first thing that we focus on is the clinical match. We actually have a clinical taxonomy-based approach that ensures that based on your clinical need, your condition, your diagnosis, the procedural need, you get to the right doctor based on their clinical expertise. But then also take into account the hundreds of other criteria that we all care about: insurance, location, it could be gender, languages, et cetera. We have about 200 attributes that we manage within our platform. And then finally, as Vince was alluding to, really our platform is all about creating liquidity of information. Today we have a fairly basic set relative to other industries, certainly, of data that we use to help create transparency around providers, around what they do, around what times they're available, how much they cost, things of that nature. Certainly the holy grail is the ability to do that with quality data and be able to apply a lens around healthcare outcomes and who is truly the best doctor to take care of you to ensure that you're getting the best long-term care. So we are certainly moving in that direction, and ultimately have a vision and a goal of making it easier for everyone in this room to not only get an appointment with a doctor, but ultimately get to the right doctor the first time.
Okay. Mark, Senior VP Navinet.
Thank you. I love the passion. So Mark Dudman, I'm the SVP of Product Development and Operations for Navinet. Navinet is a local Boston-based company, and we're relatively small compared to Intel. We're about 350 people here in the Boston area. We run a real-time network communications platform, and that platform is specialized in the area of what is referred to a payer-provider in healthcare. And basically what that is the communication between insurance companies and doctors and physicians, hospitals, clinicians. We have about 60% coverage of the US for physicians and hospitals, and we work with about 40 or more now insurance plans and payers with regards to anywhere from Aetna and Cigna at a national level down to the regional Blue Cross Blue Shield Association guys. We cover about 47 million lives nationally right now, so a pretty good spread of information and flow of information. Navinet started in the early days with the two fundamental questions that doctors seem to really care about. Will I get paid? As far as eligibility and benefits checks, and then the claim status inquiry of when will I get paid now that I've actually seen somebody. So those are administrative workflows. We do things like referrals and authorizations as well. But in the last several years, we've also moved into both hybrid and clinical workflows to deliver continuity of care and care gap information as well as document exchange. So that's a little bit about Navinet. About myself, I'm a geek at heart, so it's a real pleasure to actually be here at MIT. I'm a computer scientist is my background. I've only got 2 years in the healthcare industry. I've got a lot of platform experience in telecom, financial, and billing. So I think I bring a pretty good flavor to the platform discussion.
Thanks, Mark. MJ, General Manager of Consumer Health at Intel.
All right, so thank you, Vince. So like Vince said, my name is Michael Jackson, so no relation, if you were wondering. But at Intel, most of you have probably heard of Intel. And as you probably know, Intel is typically an ingredient company, right? Intel Inside. So we power at many levels the innovation and the solutions that consumers use every day. But specifically, my role at Intel as the GM of Consumer Health is to further the development and the innovation within the consumer space. So I'm literally coming at this from the other angle as from many of my counterparts here on the panel. So I would like to start with a question. How long is consumer health going to be a thing? And a lot of people, usually when I ask that question, they say, well, you better hope it's going to be a thing for a while because you're going to be out of a job if it's not. But what I mean by that is how long are we going to refer to this as consumer health? I mean, remember when we called the TVs high-def TVs, or before that it was flat-screen TVs. Way back before then it was color TV. Well, now it's just TV, right? You tell your buddy you bought a new TV, we assume it's flat, We assume it's color. We assume it's high def. So how long is consumer health going to be a thing? Another misconception is that when I say I'm the GM of consumer health at a party, my friends go, oh, that's pretty cool. You deal with like the toys, the stuff that we buy at Best Buy. How many people in here are wearing a smartwatch or a fitness band or something like that, right? So that's true. That is part of the consumer health ecosystem, but it's much bigger than that. That's the tip of the iceberg. That's where all the data is being generated. And conservative estimates say that by 2020, we're going to have anywhere from 50 to 200 billion of these types of devices, also inclusive of IoT-enabled devices, on the edge. That's a lot of devices. That's a lot of data. It's a lot of valuable information. But what many people don't realize or acknowledge is that there are countless enterprises on the back end who are just screaming for someone to confidently come in and take them by the hand and say, let me show you how to integrate all that new data into your traditional business model. Let me show you how to leverage it and use it in your legacy IT systems so that you can personalize the experiences of your consumers on the front end. So even though the gadgets are really cool, and like Mark, I'm a geek at heart, I love talking about the wearables and the IoT on the edge and how we can enable, as Intel, we can enable our partners to competitively differentiate their experiences to the consumer versus their competitors. I'm equally as excited about enabling the enterprise to confidently bring all that data into their legacy systems, into their traditional business models, and make use of that data. The previous speaker spoke to it, I think, very eloquently about how you can actually enable the consumer to be a better consumer by making specific recommendations. So my background before coming to Intel, I was the director of strategy for public sector and healthcare at Adobe. So Adobe has transformed into a market leader in digital marketing, where, again, it's about personalizing experiences for many retail type of enterprises. But here in healthcare specifically, the stakes are so much higher, right? It literally is life or death versus selling a widget versus your competitor's widget. But similarities exist as well between digital health and digital marketing. Personalizing experiences, right? In digital marketing, you may personalize an experience based on the location of the customer, based on the cookies of their browser, based on their previous purchasing history. What if you could personalize a consumer's healthcare experience based on the chronic condition that they're battling, based on the amount of sleep that they typically get, correlated with the amount of activity in their calendar? The possibilities really are endless. So I think I've used up my 3 minutes, but I'm looking forward to a very, very dynamic discussion. I think there's a lot to talk about.
All right, thank you, panelists. Let's start with the first question. What are tech companies like Apple, Samsung, Salesforce doing in healthcare? What kinds of platforms are they building? What's the strategy? What's your personal take? Are they going to be successful? I'm going to play it by ear here. I'm just going to toss it out to the panel. Talk amongst yourselves. Feel free to disagree. Go for it.
I think they see it as a huge growth opportunity. To your point earlier, it's just, it's such a significant portion of our economy that has not at all been touched by innovators like these. I think Apple and Samsung are doing a lot of what MJ just said in terms of saying we're on the data collection end of the stick, and how can we actually incorporate that into operational workflows that impact true care delivery. I think Salesforce is actually a really interesting one. We come up against Salesforce quite a bit in the market, and they're clearly making a very concerted effort to play in the space. And I think what's particularly interesting is that I think all of these companies are finding that models that worked in other industries do not, very nicely translate into the world of healthcare. For all the reasons that were mentioned earlier on the slide, whether it's regulatory, the fact that that Apple is talking to the FDA is just fascinating to me. And similarly, Salesforce and how they deal with HIPAA and privacy issues on a data management platform. It's been very interesting to see. They've actually recently announced that they are creating an entirely new product line from their Force.com platform platform to specifically address the unique requirements and goals of the healthcare industry, because they are finding that the core technology does have a lot of gaps, that can't just directly be applied. So I think overall strategy is definitely growth. They see the same opportunity that we see. They obviously have technology that can be applied conceptually, but I think they are coming across a lot of the practicalities of how those things get translated into real life applications within this particular industry.
Yeah, you're indicating what's the strategy. I think the strategy is similar to what Marshall said earlier about the goal of a platform is to expand it and extend it. And if you look at examples of Salesforce, a company that I've competed with for many years, they've built a core fundamental platform for building CRM, customer relationship management. So now they see their strategy as, well, now why not move into patient relationship management, PRM, right? That's just an extension, and they're going to use the platform, continue extensions, work with partners like Philips to make sure they can penetrate that market.
I'll actually take a bit of a contrary perspective on this, right? Yeah. So why are they moving into the business? I mean, the healthcare right now, there's just so much funding in healthcare, and the amount of money that's in the industry right now. I think the question is, why wouldn't you try to get in, right? So when I look at the big companies, the challenge that I see is, I think it was the Rock report that just came out a couple weeks ago, basically said in the first 6 months of the year, $2.1 billion has been invested in digital healthcare startup companies, really focusing on pumping money into the healthcare. When I look, I see the world as I'm a computer scientist at classical training at heart, so I am a geek at heart. But when I look at the world in ecosystems, and I see, as these companies are coming in, the biggest challenge remains there's so many parts of healthcare that are these islands of expertise, whether it's deep data, it's deep understanding, deep analytics, but the interoperability for workflows, meaningful workflows that go to accountable care. That's where the challenge is. And I think the challenge I'll make with the big name companies is, as they're getting in, I think the challenge from an industry perspective is interoperability, right? How are we going to communicate? How are we going to make those patient visits meaningful and have the data available when you actually need it at the point of care? So I think that's a challenge. I think the reason, my perspective, it is a very rich industry at this point. Not to completely disagree, but I think there's, a lot of motivation there.
So no, I think there's a lot of synergy with what we're saying, because it's a lucrative market, but the gap, and we'll talk about this later, is about the interconnectivity.
Yeah.
That's the huge gap.
So I would take the same approach, I think, as you're taking, Mark, in that I think the reason these big name companies are coming to healthcare is because of the opportunity. And I think the opportunity exists because of the disruption. There's always opportunity in disruption, and there are fewer industries that are being disrupted more right now than healthcare. So I usually look at it through the consumer lens, and I think consumerization equals competition. And many entities within healthcare are facing competition, and they're having to shift their business models in ways that they have not had to do before. And so they're looking for ways to optimize efficiencies or to think in a different way. So a perfect example would be health payers, health insurance companies. Traditionally, they were accustomed to talking to brokers or large employers, and that would determine which plans were being offered. But now, thanks in part to the Affordable Care Act, consumers have choice. That choice leads to competition, and so companies like Aetna and Cigna, they're starting to think like your traditional retailers. How can we not only attract and retain our members, but how can we earn their loyalty so that when it's time for open enrollment, these members stick with us versus to jumping to our competition. Providers face a similar disruption when we talk about going from fee-for-service to value-based, quality-based reimbursement. In fact, meaningful use stage 3, not many people realize this, but there's a stipulation in meaningful use stage 3 that says in order for providers to get the vast majority of the incentives available, their patient population, at least 15% of their patient population, needs to have electronic records that are inclusive of patient-generated health data. That could come from a wearable, it could come from a survey, it could come from any source of information outside of the hospital walls. And so, again, I think it's opportunity and disruption, and that disruption is what's driving many of the big companies to healthcare.
Okay. Next question. Let's just shift gears a little bit. You've touched on some of this. What are the main drivers of platforms emerging in healthcare? What are the industry dynamics that give rise to platforms?
I think actually consolidation in general is a big one. We see a ton of M&A, both on the hospital side and now even on the payer side, with the recent Aetna and Humana deal. And our customers, we actually target hospital systems that are undergoing M&A because after they do the deal, they end up with 20 hospitals, none of whom have the same platform, none of which talk to each other. The doctors don't even know who they are, so they don't know who to refer to in terms of their colleague panel. And so I think just the industry dynamic around consolidation is actually driving a lot of need to invest in technology that then brings all of those systems together.
Yeah, my view is from a provider perspective, hospitals are typically built to support a full function. And as we see more consolidation in the healthcare market, more hospitals are acquiring other hospitals, they're building out larger networks. What we see is that we see a lot of still siloed businesses throughout these individual hospitals. Each hospital still has a CEO, each hospital still has a CFO. These are still siloed organizations. And in the world of equipment, we even see that some hospitals, they don't even know that the same device that they have is available just sitting in the hallway somewhere in another OR. So breaking down those silos, I think, is a really, really important thing to really improve the care and reduce the costs that hamper the healthcare system.
I'll go back to the accountable care, and I think the thing that's going to really drive the emergence of platform is the ability, as with meaningful use, as we're holding providers accountable for managing their patients as a population health perspective, you have to be able to do several things. You have to be able to measure that in the aggregate. You have to be able to have the deep analytics to not just from a single provider, but from a region or geographical center all the way to a national level, be able to manage and understand patient health and what those trends are. So I see the platforms that having to have the ability through meaningful use reform, both the carrot and the stick. Initially it's the incentives with the providers, but at some point at the end of meaningful use 3, there has to be that level of adoption where you actually have true end-to-end accountability. And we've got to prove at the end of the day, through the ACA and accountable care, that population health is actually getting better.
What is population health? I mean, that's a term we use very much internally within our industry. And before you answer that, let me say, come on up. Let's have some questions. I've asked a couple, but what's population health? And let me invite people from the audience to step up to the microphone too.
So I'll start with that one. One of my favorite examples of a potential population health use case would be the Ebola scare. So remember, not long ago, a year or so ago, there was this big Ebola scare, and asymptomatic patients were told to go home and self-monitor, right? So let's say you've had potential exposure to someone who has Ebola, but you're not showing any symptoms, so you're told to go home and self-monitor. What does that mean? It means every hour or every couple hours, you write down what your temperature is, you write down what your heart rate is, you may write down how much sleep you're getting, and if anything falls outside of a particular range, you pick up the phone and you call, 1-800-oh-crap. So imagine, though, if instead of being told to self-monitor, you're given a wearable or you're given some sort of device that would automatically track all of those variables. And that data could automatically be sent to a central location that would know automatically if someone who is suspected of being exposed has in fact been exposed. Imagine some big command center with a big map on the wall with dots, right? And each dot represents a wearable. Every time a light lights up, that means someone has readings that are outside of normal range. Well, if you have multiple wearers of these wearables, multiple dots means multiple potential cases of Ebola. And clusters could mean, an outbreak, or it could mean, something serious is going on. So the same type of approach could be used in modernizing clinical trials. It could be used in a number of ways. So again, it's taking the consumer-facing, the engaging, immersive experience and leveraging them in an enterprise to optimize efficiencies. And that's just one example of how I see population health management.
Okay.
I don't want to deviate too much from population health, but to use the Ebola example, on the supply side, there was a large demand for gloves, and there was a shortage of gloves. And so hospitals were scrambling on how to get their hands on gloves. And so there was no central system to kind of help them identify where can we get these orders. And there was just a lot of chaos in trying to actually secure gloves to treat patients because of the outbreak.
Good point.
Okay. We have a question, although this gentleman doesn't have a name tag, but we'll let you ask a question.
All right. Happy to do that. So the question's really simple. Google tried Google Health, Microsoft tried Microsoft Health Vault. They were some of the most knowledgeable platform companies in the world. Why did they fail? I have an outsider's view of why that happened, but I'd really love to hear what the insider's view of why that happened.
Great question. Haven't we been there before?
I'll take a stab at it. So this is my personal opinion based on projects that I've worked on. I've worked with the VA on the Blue Button project and others. So I think many of the initial stabs assumed that individuals were interested in taking total ownership of their entire record and being responsible for it and keeping it on a thumb drive in their pocket and taking it to their primary care, then taking it to their specialist, and then putting it back in their pocket, and having them update the thumb drive, having the provider update the thumb drive, and then the consumer is the sole owner of the healthcare information. I don't know, I mean, I'd love to take a poll of those in the room who would rather own that thumb drive and be totally responsible for it in addition to all your other responsibilities in life versus having access to it and determining what third parties would have access to various parts of it. So I think that could be why some of the initial projects didn't catch on.
I'll say from a workflow perspective, from either clinical and administrative, I think looking at it from a consumer perspective, the collection of that data, the aggregation of that data, I think was a very strong initiative. And I think there's a lot of focus in that area, especially with deep analytics right now. But there hasn't been a whole lot of tying that into the ecosystems, right? And that's why we're here. We're talking about platforms, talking about ecosystems. And from my perspective, that was the biggest challenge of you've got to tie it into a meaningful workflow, right? As an example, when you do a physician visit and you're at the point of care and they're checking you in, if you're diabetic and you haven't been checked in the last 6 months for your glucose or what your vision is or what follow-on symptoms are, then that's the point of care where you need to actually engage, and that's where information is meaningful. So it's really kind of connecting the flow of the deep information to the point of time that it's actually going to make a difference. So I think, as we were talking about the large companies earlier, I think as these large companies come in, it has to be part of the overall workflow that is adding value, right? It gets back to accountable care. Is it really accountable, and is it getting better?
And I think related to that, specifically on Google Health, I think there was actually a product market fit issue there where the very people who need that the most are the people who have the 8 chronic diseases and comorbidities and whatnot, who certainly at the time, and maybe even not today, are not the ones who are on a mobile app or using Google as the first place that they think to go to get that information. And it was actually funny, I was on a roundtable panel with Vinod Khosla, who I deeply respect, but obviously has a whole mantra around everyone being the CEO of their own healthcare. Literally sitting next to the CEO of Mount Sinai Hospital in New York. And Vinod walks in, he's got like 17 devices. He's like, I'm collecting 1 billion data points about myself every day. This is great, I'm gonna be the CEO of my healthcare. And then you see the CEO of Mount Sinai slowly putting his head in his, and he's like, listen, I have millions of patients who walk through my halls every day who have no interest in being the CEO of their healthcare, and you don't even know how. Like if you showed them a device, they wouldn't know what to do with it. So I think some of it was just that mismatch between the proposed solution and the actual persona of the population that needs it.
And to put a quick statistic behind that, 5% of the avoidable costs in healthcare, or 65% of that cost is committed by 5% of the population.
And they're all over 65 years old. And
Exactly.
yeah,
And they're not wearing Apple Watches.
correct.
Those are great answers. Thanks very much. I do wonder the extent to which they also scared the doctors and insurance companies with the analytics from third parties. So I wonder if that was another piece of it, but I really appreciate those answers. Thanks.
Okay, thanks, Marshall. Another question from the audience.
Thank you. My name is Mary Gray. I'm a researcher at Microsoft Research. And I think my question is maybe going to this theme of, and perhaps the tension between setting up platforms as a place where we sort of, another way of phrasing it, maybe outsource a lot of the value and collect value from folks who are sharing information to a setting where perhaps it's not about so much pushing out and working outside, but trying to connect people who are going to provide services with service opportunities that are flowing through the signals of a device that's saying, so I need help. So the question I really have is, how do we think locally about the sorts of problems that are identified through platforms for healthcare, through devices for healthcare? How do we connect a very, very local need, especially for national, really global companies that aren't thinking locally?
Great question. How do we think locally? And I'll perhaps add to that, I would expect, you agree, platforms are going to look very different in healthcare than they do internationally, nationally. Panelists?
So,
Well,
no.
MJ, all yours.
So thinking locally, I think, refers to the experience. And the experience needs to be, where'd she go? Oh, okay. So thinking locally refers to the experience, and I think the experiences need to be personalized in order for it to resonate with a local group, a local demographic, or even as local as you can get individually. And so the way I define experience is really in three parts. There's engagement, right? So it needs to be immersive. It needs to speak directly to the individual, because if it doesn't, you're not going to continue to wear it. Many people buy these wearables, and within 6 weeks or 6 months, they're sitting on a shelf someplace, right? So in order for the long-term workflow to continue to work, it needs to continue to be worn. And so the engagement needs to be there. The second piece is efficiency, meaning it needs to solve a problem. And each of us have different problems that we're trying to solve. So it needs to address a pain point, whether it's an enterprise pain point or helping you manage your diabetes or whatever the case may be. And then the third, I think, is effectiveness, or more specifically, measuring the effectiveness in an ongoing way of the first two. How well is the engagement taking place? How well are the pains being addressed? And if they aren't, how can you fix that in real time or as quickly as possible so that the engagement continues and that the pain point does get fixed? And so that's how I would approach it.
We've got time for one more question from the audience, and then we'll have to wrap it up.
Thank you. My name's John Harris, and I run a little business that provides a platform for exchanging documents in healthcare. I'm really interested in the challenges that are there for interconnecting the data for individual health records, right? And the requirement for interoperability of these systems, and the challenge of that requirement for us as consumers for having our data interconnected, playing against the interests of some of the vendors that are developing systems to support this data, who are all driving a philosophy of independence or proprietary platforms, and trying to keep their data within their own systems, trying to keep their own independence. I was interested to hear your thoughts on that, and whether you had a different perspective.
Yeah, that's interesting. I'll kind of borrow some of the comments that Mark said earlier when he's talking about the workflow. One of the things around, a lot of discussion around interconnectivity is around the health information exchanges, the HIEs. And the HIEs are great. They're regional. They have lots of information about patients in that region. They allow physicians to go in as a portal to go in and search for information. The problem is it's that workflow. They have to go in and use this portal. They have to go in. They have to search and pull this information. So I see that as one of the major stumbling blocks. What I'd like to see HIEs do more frequently as they move is to move into more of a platform model where they're starting to provide more services, and they're starting to push information information back to the healthcare and the healthcare providers, the ACOs, healthcare providers, physicians. For example, imagine an HIE that has a pharmacy monitoring system. So they're pulling information from pharmacies, or an HIE can actually detect that a patient in one hospital was discharged, but they showed up at another hospital, and that physician needs to know that information, right? So I think we have connectivity with HIEs, but we really don't have really great interoperability, and those services can help in that regard.
I think there's also
Go ahead quickly, and then I'll.
Quick thing, just on the regulatory side, obviously, so much of the push of meaningful use and High-Tech Act was around interoperability. But in practice, what we see, we rely on the ability to suck data out of these incumbent EMR and practice management systems. And even though they all, by the letter of the law, allow for interoperability, the way that it gets implemented sometimes is just horrendous. They charge for it. They charge tens of thousands of dollars to build individual interfaces into individual practices, which is completely, untenable for some of the health systems that we work with. So, we certainly look to, number one, just regulators, and hope that there's more enforcement of kind of practical implementations of the law. But some of it's cultural, and I think that is a big challenge in this space, is just the incumbents have, not a lot of incentive to be more liquid about their content.
Okay. The network has told us we have time to run over, so we're just going to bump out the local news, and we have one more question.
Thank you, Vince. So I'm actually going to follow up on a lot of things that were just discussed. My name is Hemant Bhargava. I'm a professor at UC Davis. I do research on economics of platforms also. So my question was building on, I think, what Vince started off with, that there is so much fragmentation of platforms in the healthcare world. You have hundreds of non-interoperable systems on which apps are running. And my question is really, what will it take us to get past that into fewer non-interoperable platforms? Is it necessarily an external force, or will it come from within the internal or market forces within the healthcare system? And one reason I'm asking this, there is also, there are obstacles, and one of those is that healthcare is very local, unlike social media, and local, I just mean not just spatial local, but we're going to see greater weight of HMO-type organizations, and therefore the majority of their patients are going to receive all their care within the same system, and therefore the need for interoperability for those patients is lower. They're not going to go across to another healthcare organization. So given that, I really wanted to get a sense from you whether you think we really need external forces to force interoperability, or it's going to happen some other way.
Panelists, given where we are, I'm going to play moderator Twitter. You each have 15 seconds to answer the question, how does healthcare get its spit together? Go.
I'll go first. Absolutely. The industry has not shown that it can possibly regulate itself. It needs outside regulation. You have to have both a carrot, but you also have to have a very big stick. There's a lot of money. There's a lot of insurance companies and vendors who are making a lot of money are not incentivized to change in any way at this point. Until you have that operability, you're not going to have that. So the other thing is you have to have the right standards. I think you mentioned FHIR earlier. I think FHIR is a great first step in that interoperability to actually get those workflows to go edge to edge.
I think you need both internal and external. I'm optimistic that there actually are some hospital systems that have a nationwide presence that are sort of the big players in the space that are pushing the vendors because they have such market power to open up their systems and not pay for it. So I think it has to be a combination of both.
So I would say there's a vendor term many of you may not know, but it's SOW, share of wallet, right? And so vendors look to extend the share of wallet in most environments. And that's why many of the platforms are closed. They figure if they have a foothold in this particular solution or product, they can extend their share of wallet and have a closed platform that would sort of capture market. So I think I agree with Julie that it will take both internal and external forces, but primarily we need to, from the vendor community, sort of look at this in a modular way so that customers can pick which parts of the platform are applicable to them and use only that part rather than having to buy soup to nuts everything belonging to X company.
Michael, you get the final word.
Well, these guys answered great answers here, so there's not much for me to extend. But one thing is, if you look at what Uber has done, right? We mentioned earlier in the session that Uber has really taken off. Uber, just like in healthcare, they still face regulation, right? Regulation hurdles all over the place. So, being able to start small and to kind of dance around the regulations, and then sometimes just go, having a vendor, and Julie mentioned some of the power from the vendors. Vendors can provide some influence over legislation. So if vendors can help, I'm just looking at it from the vendor perspective, can be successful in certain markets and solve certain problems and show the value of doing this, it provides a data set to help influence and change regulation.
Thank you, and a hand for our panelists.